Okay. All right. Good. People are here. Audrey, how are you?
I'm well, thank you. How are you?
Good. Had dinner with Dr. Freeman and Al Charchet last night. He said, not Al. Al doesn't know you. I'm sorry.
I don't know him either.
You don't know Al. But Dr. Freeman said you were doing really well in the teaching practicum. So,
Oh, good.
okay. Got a bunch of friend requests from that picture. And so my wife, I said, who are these people? She said, they probably go to the school. Oh, yeah. Okay. All right. So that was fun. Chaplain, how you doing?
Fantastic, sir. How are you?
Bright-tailed and bushy-eyed, working on it. Pastor
Great.
Josh,
Doing good, sir. How are you?
I'm all right. Okay, so let's talk about this being the last class. All right, we're not gonna have a class next week. I'm gonna give you guys a chance to get all your other stuff done. Plus, it's not fair to have a Thursday class when the term ends on a Friday, right? So both of the PowerPoints, 10 and 11, are in this week's deal. So you'll be able to download those. Now, that's the good news. I may have gone a little crazy on the final exam. All right, I'm going to show you why here in just a second. The questions are a little more complex. A little more complex. They have elements to them. So what I thought I would do is share my screen with you and show you what I'm talking about to kind of give you an idea. All right, there you are. Yeah, that's the one. Okay, so this is the super secret instructor's view. So don't you take anything from it if yours doesn't look like that. So let me show you. Just, oh yeah, and there's a password you have to get in. Okay, you have to have a password, and you have to have a proctor, unless you happen to know the password. Okay, I'm just saying. Okay, you can't, Chaplain, you see why I went to jail, right?
It's also been the same password for like four other
I
classes.
know.
Just
I know.
figured I'd toss that out there.
I like being consistent, all right? Plus, since I have so many classes, I don't have to remember what the password is, all right? So that's great. Now, if you do have a proctor that's going to be contacting me, have them let me know what class it's for, please. And because usually I need the password for, and I blank on the name. And so please have them say for the addiction class, okay? What's the matter? Chaplain, you okay? Just let me know. Just tell me who you are. All right. Do I need to blow that up or can you read that okay? You read all right? That's the first question. I want to get all the questions are like this. Okay. Each of them have specific elements that I'm looking for. And so I want you to make sure and have all of those specific elements in it, in your answer, okay, in your 500 word answer. Please do not go over 600 words. And you know who I'm talking to. Please do not go over 600 words, all right? 500 max. Are we okay? What are you laughing so much? You're in a jail and you're laughing. What is wrong with you?
I'm just saying my words are 501 and holding. That's all I'm always
Okay, all right, all right, all right. Yeah, no, I got a 1,000 word from an undergrad the other day on a midterm, and it was a 300 word answer. And I'm thinking, okay, one, do I really want to read 1,000 words? Yes, I did, but it was like, really, really, really. So get as close to 500 as possible. That'll be helping you as you move on with other things. Let me do this. Everybody signed up for next classes and all that kind of stuff. Any questions on that? Oops, hang
I
on.
have not signed up yet.
I have
So I guess I didn't clock that it was time to do that for fall.
Not good. Not good.
Is there anything different that I need to do for the capstone?
You know
Is
what to
that a
do.
different?
And we'll be in
Okay, I'll
touch over
just
the
get on there
summer
and look.
over that also. Yeah. So, reach out
I
to me
meant for registration.
for registration. Yeah, I think the capstone is a
It shows
five.
up as something.
Yeah, it shows
Okay.
up something. It's a 500 something or other. Yeah.
Okay.
All right. Yes, sir.
What
Oh, I'm sorry. We weren't through. Go ahead, Audrey.
I was just going to ask really quickly too, it's just more of a advisor question, but for applying for graduation, then am I supposed to put any like extra files or anything like that in my portfolio or do you know anything
I,
like that?
I don't know. The person
Okay.
to ask would be, of course, Dr. Freeman, but he'll refer you to Jennifer, I think. So
Okay.
why don't you just start with Jennifer and
How do
ask
you say her last name?
Roper.
Roper. Thank you.
Well, she
I've
is
been avoiding saying it this
that's
whole
the
time because I'm
that's the married name, I think, right? Roper. Jennifer something before. People get married, it's just keep the same name. Don't confuse me like that. All right, that's it for you, Audrey. Okay, Chaplain.
There was a question. I always take 3 courses over each trimester, and there was a question. I know I'm short 2 counseling classes, marriage and family and community crisis. They're attempting to do. I'm assuming you're in on that conversation. I've got a practicum, systematic theology, and they're trying to figure out which one is available for the fall term. So just kind of figured I'd loop you in as the counseling chair.
I mean, that's not a brain teaser. That's a hang on.
It needs to be marriage and family because that's the only one I need left.
That's what I thought too. And I thought that was available in the fall term.
I don't know.
And
Let me
then
look.
I would do the capstones as well as community crisis at some
No.
point. Same
You're
thing.
just trying to beat me, Dean. That's what it is.
I'm trying to do whatever it takes to wrap it up in May of 27.
Make me come to graduation for you two, right?
There'll be a gas
Fully
card in the mail.
Yeah, that was hard. You got to explain. I'm looking this up right now. I'm not ignoring you. You have to explain to people when they come to Texas that all the cities are far apart. Okay, they're far apart. The big ones especially. So when they said we're in Corpus, well, they weren't in Corpus. They were in Calallen. All right. What's right next to Corpus? It's 50 miles from my house. All right. So okay. Well, anyways, I went. Chaplain, I'm gonna look you up right now.
Okay.
All right. This thing. Yeah, there we are. All right. Okay. No. Okay. All right. I'll get them to you. All right. I'm gonna make a note and get them to you.
No worries.
Let me
Just I
flip it.
wanted you to be aware of that with that kind of question mark out there.
Yeah, I'll work it out. One way or the other. I mean, I know I have 3 classes generally, right? So and they've got someone I think who's going to teach the undergraduate class in the fall. So then I would only have 2, and they could add the extra class to help facilitate both of you getting things done. So we'll go that way. I'll talk to them.
We have
they're-
all summer to figure it out. So
I said that last summer too, and I said I'm just going to write all summer long. I'm not. No, not doing any of that. Pastor Josh, did you have a question?
No, sir. I didn't know it was time. I hadn't even looked at it, so I don't know what to ask.
Yeah. Good. Well, there's an audit thing. There's a student audit deal in your portal, whatever they call it, Stargate. You can open that up, see what classes you still have to take, and all that kind of thing. All right. Good. And if you need help, let me know. Otherwise, get Jennifer or Dr. Freeman involved.
I didn't know it did that. I was actually curious. Okay.
Oh yeah, I'll do it. Okay, what else was I going to tell you? Okay, Proctor, password, both PowerPoints are there. My grading, I can start grading tomorrow because the final exams are all up for all the classes. So I will have the grading done by Sunday for that. Try and get everything in this, next week, whenever you want. For if you're behind in something, try and get it in. I technically have until the following Friday after classes end to turn in final grades. Okay, technically. I prefer to get them in as soon as possible. So if you need extra time, reach out and let me know by email. I don't think they have the form on the new thing anymore. So just send an email if you need anything, and I will work it out for you. You're my graduate students, 2 of whom will be meeting in person next year in New Orleans, God willing. Or not. We'll see. I will not be driving. I promise you that. Okay, so let's do this. I'm going to go through these with you today. There's a couple of the deals. That way you can question any questions you may have. There we go. So first part's on holistic and integrative approaches. In other words, spirituality, ethics, models of addiction recovery, I'm going to introduce you to a new mode and model for psychology that has to do specifically with spirituality and the biopsychosocial model. Holistic approaches to addiction recovery treat the whole person by addressing physical, mental, emotional, and spiritual dimensions, rather than just focusing on substance cessation. I like the holistic approach because it treats a person as though they are actually a person and not someone with a problem. All right? That the problem is the problem. I get that. But when we're talking about a person, we want to treat the whole person as a person. So these integrative methods combine evidence-based medical treatments with complementary therapies like mindfulness, yoga to promote comprehensive healing. These approaches recognize that addiction stems from interconnected factors and aims to restore balance across all aspects of life, and spirituality often serves as a foundational element, fostering purpose and resilience during recovery. When I say spirituality, do not think it's exclusively Christianity, okay? So these approaches don't alienate Christianity, they don't push away Christianity, but they also embrace other belief systems, whether it's Buddhism, Hinduism, any of them, any of the isms that are out there, Muslim, all that, okay? So as we look at this, what I want you to see is spirituality has now climbed to almost the top in terms of addiction and addiction counseling. Pastoral counselors, you can assist with that element if a person's in addiction or in addiction recovery. What did I just do? I pressed entirely the wrong thing. All right, so let's keep going. A little bit further here. Spirituality in recovery extends beyond organized religion. It includes a sense of connection to something greater. Nature, community, personal values also are included in all this. Many individuals in recovery report that spiritual practices help fill emotional voids left by addiction and build inner strength. It is not about religion. It's about connectedness, connecting that person to God. First start teaching counseling and counselors. What I tell them is our job is to draw them closer to God. That's our job. Let the Holy Spirit do his thing. We're going to draw them closer to God. So spiritual practices, what are some Christian, Protestant spiritual practices? I know. We want to default to prayer. Prayer is a spiritual practice. Prayer is talking to God and listening, okay? So let's not call it a spiritual practice. I'm doing God a favor by talking to him. No, you're not. You're not doing a favor at all. You're doing a favor if you listen and do what he tells you to do, but it's not a spiritual practice. Baptism is a spiritual practice, which you theoretically should only do it once. You hear me so far? You see the struggle that we may have as Protestants? Well, there's the Lord's Supper. I'm glad you brought that up. The Lord's Supper can be given, according to all the traditions, whenever. It doesn't have to be every third month or every second Sunday or every Sunday. And it can also be done at Bible studies and all kinds of services, and when you go out and meet and greet. What? Yes. I will on occasion go to someone's house who's having some difficulties, not just necessarily for counseling, just to be there, hang out. And guess what Mike brings along with him? A big jug of Boone's Farm apple wine. I bring along some grape juice and some bread. Why? Well, because we're going to have a spiritual practice. Sometimes people don't want to do it. You can only do that in church. Jesus didn't do it in church. So we can use that as a spiritual practice for Protestants. I know, kind of wrap your head around the intensive things that could do for you in your ministry if you chose to do it that way. Now, if you disagree, that's fine. Feel free to be wrong, but you can just understand what's going on, right? This is not something that's just in there. The pastor has to do it. Okay, then forget all that. All right, so meditation, Christian meditation, meditating on scriptures. That's a spiritual practice. Anybody know how to do that? I just think about it a lot, right? Yeah, there's that, sure. Or you can emphasize certain words, which I love doing because it just kind of changes everything if you're more, try it with John 3:16, every other word. So we look at it this way. What are the spiritual practices in our faith? Well, for AG, right. So find them, look for them, and you can also use them as pastoral counselors in your office. Lord's Supper in your office, yeah. Nobody's going to get mad. Well, the pastors can get mad unless you didn't ask ahead of time. But you understand what I'm saying here. We look at religion, we're looking as counselors at spiritual practices. Okay, questions or comments about that?
I saw a funny meme this morning that said how surprised they were to find that the Protestant people that interpret the Bible the most literally are the ones using grape juice for communion. And I was like, oh, that's funny. Anyway,
Yeah,
just as funny that I thought this morning. I just thought it was cute.
it's an interesting concept. So probably I shouldn't talk about it here, give you the history of all of that and why it happened.
Sure.
Yeah, I get in lots of trouble.
I'm not trying to meddle. I just thought it was funny this morning when I
No,
saw it.
I just think like it's a better idea. Let other people deal with it. I'll deal with counseling and that. All right, so programs incorporating spirituality show improved coping skills, optimism, reduced relapse rates through enhanced meaning and hope. Ethical integration requires respecting diverse beliefs without imposing specific doctrines. Can we do that? Oh, yeah. We can. And now, lady and gentlemen, I am going to introduce you to a wonderful new model. You ready? The biopsychosocial spiritual model. Oh, yes. Those of you who know me know I'm a big fan of the biopsychosocial model. This I'm fond of also in terms of addiction recovery. It's influenced by addiction is influenced by biological vulnerabilities, psychological patterns, social environments, and a spiritual disconnection. Not a religious one, a spiritual disconnection. So this framework supports integrative treatment by addressing root causes across multiple domains simultaneously. And in this case, recovery under BPSS emphasizes rebuilding healthy relationships, managing stress, nurturing spiritual growth for lasting change, and it has proven relevant across cultures, including those with strong religious contexts. And we're going to go through that here in just a second, but I want you to look at that list. And I want you to think about what the church is supposed to do. Are you looking? Are you reading? Are you soaking up what I'm spitting at you here? All these different things we do in church anyways, are supposed to. It's a goal. So kind of keep this in mind. Of all the models that I've shown you thus far, this one is most likely to agree with Christian doctrine. Most likely to. All right? BPSS model. All right. Holistic framework, understanding, treating addiction, extends the traditional biopsychosocial approach by incorporating spiritual dimensions. Also, recognizing that the addict affects the whole person. Body, mind, relationships, sense of meaning, all of this treats a person like a person. So the model views addiction as a complex, multifaceted disorder rather than a single cause issue like moral failing or purely a biological disease. So treatment and recovery must address interactions across all 4 domains. That's if you want sustainable outcomes. So in theory, you could succeed in 1 or 2 areas, but you're not going to have sustainable outcomes because they're most likely going to relapse or struggle in other areas or find a new addiction. Okay? So that's why I'm a big fan of this in terms of pastoral counseling. we can take this to the pastor or to a church and say, look, see, this is what we do. Because it is what we do. We're not just focused in on the spiritual. We're also focused in on the mind, his mind's being renewed. The physical, as the body of Christ. All of these things, the emotional, the social, all of these things we are interested in and want to help with. Here's the model to do that. All right? So a little bit further. In addiction care, this model, the BPSS, promotes integrated personalized interventions. Integrated personalized intervention. Each one is entirely different from the other. Those interventions foster a comprehensive healing and long-term recovery. Historically, the BPSS model evolved from the biopsychosocial that was proposed by George Engel in the 1970s, which challenged purely biomedical views of illness. Engel got in trouble early on with medical doctors suggesting that you don't just give people medicine to make them feel better or to help their long-term recovery. They didn't like that. Doctors no like. No. We do procedures, we give medicine. That's what we do. That's why people get better. That's the argument. That's what the argument was. It's a behavioristic model within the medical community. And to a degree, today, still is. They still got to fight against this whole idea of spirituality having an effect. But we have chaplains in hospitals. Right? But there are, it's funny. I'm just going to bring this up. There are times where my wife is telling me about situations at the hospital with patients. They're being difficult. They don't want to leave the hospital, or they act out, do that. So I said, have you sent in a chaplain to talk to him and find out why? Why do you feel this way? Let's talk about that. Because the nurses are not going to have time. The doctors aren't going to have time. But you roll a chaplain in there and let's just talk. Make them part of the team. And she said, well, we've got 2 chaplains. One you met. And one I haven't met that seems to do pretty well. And so she asked him to go in and deal with certain few patients and came out with answers. Because nobody was really asking. And no one was really listening. The guy was just mad, didn't want to be rolled over because he had bed sores and all this other stuff from at home because it's painful. But the reason he got the bed sores, no one had bothered to listen to or to find out, to address those issues. He was depressed. He didn't want to get out of bed. So chaplain was able to find out. That's part of what the biopsychosocial spiritual model does. Engel faced that kind of issue in the 70s when doctors and nurses weren't trying to hear anything about spirituality. Weren't trying to hear anything other than procedures and pills. So it was kind of a new thing. So adding the spiritual component acknowledges that issues of meaning, purpose, values, connection to something greater play a key role in addiction, vulnerability, and recovery. So the holistic shift moved addiction treatment away from punitive or moralistic approaches towards a more client-centered, strength-based care that respects the full human experience. Biological definition, or dimension rather. We're going to go through these dimensions. Now I'll start here because it's the most obvious. The biological aspect focuses on genetics, brain chemistry, and physical effects of substances. Addiction often involves changes in the brain's reward system, the dopamine pathways, and it leads to tolerance, dependence, and cravings. When I'm speaking of tolerance here, that means they can tolerate taking more of the drug without having the desired effect, so they end up having to take more. Become dependent on it, it's not there, the cravings happen. Factors like family history, neurobiology, and co-occurring medical conditions increase that vulnerability. So in treatment, this dimension is addressed through medication-assisted treatment. It's called MAT. Detoxification, nutrition, exercise, medical monitoring to restore physical health and reduce withdrawal. So the biological aspect here is all the things that we can measure. We can measure brainwave activity. We can measure dopamine levels. We can measure all the blood work and things that they've had or don't have. And we can generally trace things back 90 days to get an idea of where things are going, depending on the drug that you're testing for. All right. So in this case, this is the simplest. And by being simple, the doctor said, we're going to leave it here because it's a physical thing. Engel said, wait a second. No, that's not the case at all. And started doing research studies. Where? At hospitals. And found out things change rather quickly when you incorporate these other elements into it. So that's the biological. Psychological dimension. Well, this includes thoughts, emotions, behaviors, trauma, mental health disorders like anxiety or depression, coping mechanisms or lack thereof. Many use substances to self-medicate emotional pain or distorted beliefs. So the cognitive behavioral patterns, low self-esteem, poor impulse control, all of those things sustain the cycle of addiction. So treatment here, from the psychological perspective, is therapy, CBT, motivational interviewing, skill building for emotional regulation, trauma processing, addressing co-occurring mental health issues for psychological resilience. So here it takes a little more time. It takes a little more time to evaluate the person as a person rather than as a patient. Social dimension. The social component examines family dynamics, peer influences, community environment, cultural norms, socioeconomic status, access to substances, isolation, stigma, enabling relationships, all of those that can perpetuate addiction. Anybody see any problems here yet? You need specialists in all those different areas to do that. Psychiatrists can't even do all those things. The evaluation of their home life, well, people go out to the home and find out about it. Where they live, neighborhoods, past relationships, current relationships, all of those things. So this aspect requires expertise. Like you. You may be the person that's able to help here. All right? You may be the ones that are able to help evaluate some of these things and pass along some plan or some understanding to people who have control over the situation. So, supportive network and all of these things, employment, housing, cultural factors, all of these influence recovery. So interventions include family therapy. What? Yeah. Peer support groups, vocational training, community reintegration, addressing systemic barriers like poverty or discrimination. That is the classic biopsychosocial model, those three areas. The fourth area here is the spiritual dimension. Meaning, purpose, values, connection to a higher power or inner self, existential questions. Most of the people you're going to find will have an existential crisis somewhere nearby holding on to them. Sense of hopelessness, helpless, doom, gloom. It's always going to be this way. So addiction often creates a spiritual void or this disconnection I talked about earlier from what gives life significance. So mindfulness, forgiveness, gratitude, faith-based elements, all of those things are practices that can restore hope and motivation. Please, for spiritual practices, consider mindfulness, forgiveness, gratitude. Or the faith-based elements we already talked about and discovered. Oh, we don't have a lot because we're Protestants. I know, I'm aware. But look what you do have. All of these things can help these people. And so these are some things as pastoral counselors that you want to be aware of. In recovery, this dimension, the spiritual dimension, builds a sense of transcendence, ethical living, community belonging, all of those things beyond the substances. I know, we know that. But can we do that for others? Yes, we can. We can help with the spiritual element. We can help with the social element. We can work with all of those things together. Biological, Not as much. Just refer about to PCP. Psychological, better once you get through this program. I hope you're better equipped to do that. But for us as counselors, this is our thing. And I want you to be aware of it. All right, questions or comments? I'm stunned. All right. Okay, let's take a break. And did you notice that picture, Chaplain? That I look like a little small guy? I was sitting as far away from that camera as I could possibly get, back in a corner. I'm not up there, but I look like a tiny old man.
It had to be the angle. I'm just gonna say that. And there were two on one side of the booth and just you on the other. So the perspective is also
why-
shifted, but you're right.
This is why I don't take pictures. This is just another reason.
I need to go find a picture, evidently.
All right, let's come back in about 15 minutes. All right, 1:45, please, or whatever 45 it is in your time zone. All right. Good. Being stared at by the big dog here. Yeah, no, huh? All right, so let's talk about integration with actual treatment with the BPSS, all right? And these are different approaches that's often used in this process. So, BPSS guides comprehensive treatment plans, multidisciplinary, that simultaneously target all four dimensions rather than isolated symptoms. For example, a program might combine MAT, that's where for the biological, counseling for the psychological, family sessions for the social, and then meditation or 12-step work in the spiritual aspect. But they're doing it all at once, not at the same time, obviously, but during the life cycle of this person's addiction. This integrated approach leads to personalized care plans assessed via BPSS formulations. So it will align with models like ASAM criteria, supports multimodal interventions for better engagement and outcomes. And the benefits for recovery? Well, applying BPSS promotes holistic healing, reduces relapses by addressing root causes across various domains. It empowers individuals by building on strengths and fostering self-efficacy in multiple life areas. And so does it work? Well, patients report improved well-being, stronger relationships, greater purpose, and sustained sobriety when spiritual needs are included. It enhances empathy and care, reduces stigma, supports long-term recovery as a process of a growth rather than mere abstinence. Last part being really, really important, process of growth, not just abstinence. The person isn't judged solely on you didn't take drugs, but their inner being, how they are as a human being, how they are as a person in their family, their church, their job. You can see the benefits here, all right? So there are some challenges, and I want to bring those up right now, challenges and limitations to this particular model. So challenges include limited training for spiritual integration. The reason this program exists, the MAPC exists, is because of my dealing with pastors who just didn't feel equipped to counsel people because it was over their head. That was the sole reason that I put it together. So if it works, you can praise God. If it doesn't, you can blame me. But the point through this is that I saw it firsthand. I felt it firsthand when they were trying to minister to me. I got it. I understood why some of the chaplains in the prisons that I was in struggled so much because they really weren't trained to counsel or they weren't allowed to counsel. So as we consider these things, understand that your role in the whole format of the BPSS is the most important. If you can connect someone to God, things will flow back together. In addition, if a person relapses, there's a way back. For all have sinned and fallen short of the glory of God. And there's a way back. Okay? So that's what I'm getting at here. You're really important. Don't downplay your role for a second and realize that one of the biggest challenges in this BPSS is the limited training for spiritual integration. There's also varying cultural beliefs. But you have a question, Audrey? I'm sorry.
I was gonna give input, but we can
No, go
chat
ahead. You're
later.
fine. Go ahead. Go ahead.
I had made a post on Facebook saying if anybody has questions, I wanted to know what they were. Well, then people started asking me questions that were more personal, which is fine because I know these people, I really do. And uh, one of the questions that came up had to do with a woman struggling with whether her father, who had committed suicide, was in heaven or hell. And she wanted to know what the Bible says about this issue. And she didn't want just a fluff answer. And I was actually, prayerfully had, you know, asked the Lord about it. And I was able to pull from this biopsychosocial model because of what she'd been told. And I was like, there's so many aspects that make up a person. It's not just a dichotomous, you know,
Mhm.
way that God looks at us. It's like, you know, there are all of these different factors. And when our, you know, soul stands before the Lord and we're free from all of those things, everything is laid before the Lord like naked and exposed, and he sees all of it. And because he's good and because he's righteous and just, that then he is able to, you know, make the right call, and it's going to call that we can agree with. And yeah, you could still have hope, you know, that at the end of the day, because, you know, your hope isn't necessarily that your dad's in heaven, but your hope is in that God is good and he is righteous and just. And it was so neat to be able to pull from the model, just because so many times we think people are in control of their decisions. You know, they don't take the mental health issues into account, to where, you know, I don't know all the answers, and neither does any preacher, like when it comes to that stuff, you know, where, you know, we want to say the very best thing. And now at funerals, I'm not just going to put people in heaven, but I'm like, you know, I think that a compassionate approach, this is really the key to doing that. So I was really grateful to be able to
That's a great
pull
answer.
from that.
It's a great answer, very thoughtful answer. It's a nice.
It was a Holy Spirit answer. I didn't do
That's a good
it.
answer. I'm probably going to
But
steal that, just so you're aware. I'll let you know.
that's fine. It was a lot longer than what I just summarized it, believe it or not. You know, it's like 1,000 word essay for a
Oh, stop,
500, you know,
stop, stop,
midterm
stop.
exam.
We know that's not you. We know that's not you.
But
All right. No,
you
that's
know,
good.
it
Thank you.
might end up in a book someday. Yeah.
There you go. There you go. Let it end up in a book. Okay. Cultural beliefs. Look, in some cultures, addicts are looked down upon. That's it. You're done. Okay. Resource constraints. In other words, what areas may not fit into some sort of budget somewhere, and then measuring spiritual outcomes is a bit of a bit of a sticky wicket there as well. And so, not all individuals identify with spirituality in traditional sermons and traditional terms and tradition. Period. And that's a problem. That's an outcome issue that we have trouble measuring. But I'm beginning to come to the realization that we don't need to measure it. We just don't. We don't. Um, there's a thing with John Calvin. Somebody asked him about heaven, you know, people going to heaven and how they should live their lives and this sort of thing. And what about these people who believe in free will? John, what about that? What? And his answer I thought was very good. It's basically said, look, okay, that would be the curtains falling in the other room. Okay, so did you knock him down? Yeah. Meanwhile, John Calvin said, look, if you believe that you can lose your salvation, live your life that way. If you believe that you can't lose your salvation, live it that way, in a way that brings grace to others and glory to the Lord. That's the type of answer that we look for sometimes, right? And so for measuring spiritual belief, spirituality, do we really need to measure it? No, but we can't. We don't need to. From pastoral counseling point of view, we do what the Lord directs us to do to the very best of our ability, not being weak, not being anything, but simply being who we are and helping people in that way. So I give that to you as kind of a thing that I'm coming to, because I was still thinking there had to be a way to do it, right? But then God kind of put on my heart, why would you do it? Almost like it's none of your business type of thing. But it's my business, if that makes sense. Audrey?
So one of our books, and I think it was this class, it talked about the three blind man and the elephant. And it was like, you know, we're trying to measure and judge according to what we know and what our experience is, but it's completely different because it's the same being. And I just kept coming back to like, how is it that we're trying to define what God's roles are as each person of the Trinity by the limited information that we've been given and our limited understanding? Like, it just doesn't, and I don't know, that's probably why I shouldn't, well, it's probably why I enjoy theology so much, but shouldn't really talk about it too much. But does that make, like,
Yeah,
I
no,
don't know, like,
I
that's
hear
kind
you.
of
Yeah,
where I land on that.
we had a discussion at dinner last night. I thought this, oh, here we go. We're just going to be talking about business or something. We didn't talk about business at all. Just talk about spiritual things. And I met Dr. Freeman one time before, and Al one time before, and we've been working together for years, for years, right? But we just started talking about spiritual things. And pretty soon, we're off on the subject. Al and I are both fans of quantum theory and quantum mechanics, right? And how we can look at God from that lens and the books. And so I recommended a couple of books to him. He recommended, but the whole idea of trying to understand him from a linear perspective makes no sense. You know, you have to look at a totality, and we can't see the totality. So that was part of our discussion last night, but it leads back into this with this idea that this biopsychosocial spiritual model looks at the entire being, the entire person, and considers them individually, much as you were talking about the way God would judge someone perhaps who had committed suicide. You know, motivation, the things, all the different elements that went into that. Was the person actually in control?
What was really cool about that is how the Lord, He gave me the scripture. You know, we talked about the Word of God as Jesus so many different times in the scripture that talks about how, you know, it divides between like, you know, marrow and sinew and, you know, bone and flesh. And I was like, oh my gosh, just like it does between, you know, that which is spiritual and that which is physical, like only God can see where those lines exist, you know, and it was just like, I was excited to put that together, and
That's great.
it was neat. So anyway,
That's
wanted to
great.
share that.
That's great. I'm glad you did. That's a, I said, it's an elegant way of putting it. God really, you know, comes through with that type of thing. So successful implementation requires interdisciplinary teams. Therein can be a problem as well. Unless everybody's buying in on the biopsychosocial spiritual elements, you're going to have conflict within the team. Client-centered assessments, flexible cultural sensitivity adaptations, we need all of those when we're looking at these things. Ongoing evaluation, collaboration between medical, psychological, social, spiritual providers, they're all essential, they're all necessary, they're all needed. But again, it's the idea of working together as a team. Future directions. So, future BPSS applications may incorporate more evidence on cultural, spiritual tailoring. Technology-supported holistic tracking. Prevention programs addressing all dimensions early. But the model continues to evolve. And with more research, we'll see more information. Integrated care. Personalized medicine. But we should probably compare it against another type of model. Well, which one would it be? How about 12 steps? All right. The biopsychosocial spiritual model is a holistic clinical framework, addresses biological, psychological, all of those things during treatment, addiction for treatment recovery. In contrast, 12-step programs like AA, NA are peer-led, mutual help fellowships that emphasize spiritual principles, powerlessness over addiction, and a structured path to recovery. Both recognize addiction as multifaceted and value the spiritual dimension. The BPSS is more integrative and evidence-based across domains, while 12-step is experiential and it's community-driven. Many modern treatments combine elements of both of these groups for personalized comprehensive care. All right? How about philosophical foundations? Well, BPSS evolved from Engel's biopsychosocial model, added the spirituality as an equal pillar for a scientific client-centered approach, views addiction as a complex interplay of factors. 12-step programs, founded in the 1930s, which makes almost 100 years old, frame addiction as a physical allergy, mental obsession, and spiritual malady, which is considered to be self-centeredness, with recovery through surrender to a higher power and moral inventory. So BPSS is flexible and secular adaptable. 12-step is spiritually oriented, but allows broad interpretation of a higher power. Going to a 12-step program can be part of the spiritual aspect of the biopsychosocial spiritual model. Okay, it can be part of it. And it can be an ongoing part of it. So we don't want to throw one out in favor of the other, except when it's specific to the client. what's going to work for them. Okay. Some people don't like to be in crowds or groups, and so they're not going to go to group. Okay? They're just not. So we can see both of these as being quite useful. All right, let me go to this also, get back right there. So biological dementia, I just want to touch on this between those two groups. BPSS explicitly includes genetics, brain changes, withdrawal, medical interventions like MAT, detox, nutrition, exercise. They incorporate all of that. 12-step acknowledges the physical allergy to substances, but focuses less on a medical management, traditionally emphasizing abstinence without pharmacotherapy. Okay? Though many members now combine it with MAT. So BPS offers a stronger integration with modern medicine. 12-step excels in long-term behavioral support for physical sobriety. Now, if we examine it from the psychological dimension, these two guys, BPSS incorporates evidence-based therapy, CBT, trauma work, motivational interviewing, all that, to address thoughts, emotions, co-occurring disorders, and coping skills. 12-step promotes psychological change through steps like moral inventory, which is step 4, admitting wrongs, ongoing self-examination, fostering insight, and accountability. So BPSS is more structured and clinical, and 12-step provides peer-driven emotional support and spiritual tools for inner transformation. You can see how they would dovetail together in the spiritual aspect, but we can also see the clear differences. In one, BPSS is dealing with an individual through professionals, where 12-step is peer-led, and as a result, that's where you're getting your advice and motivation, success, all that from. So it could be long-going or long-term as it goes on. The social dimension. Both emphasize community, but BPSS systematically addresses family dynamics, socioeconomic factors, all of these things that go with addiction, stigma, employment, cultural influences. And they do it through therapy and then reintegration. 12-step builds powerful peer support networks, sponsorship, meetings, and service work that create belonging and accountability. So 12-step often provides more accessible, lifelong social fellowship. BPSS allows broader professional and systemic interventions. So what we're looking for here is the fact that BPSS is going to be short-term. They're not going to be going through all this their entire life, where 12-step can give them a place to go their entire life for support, mentoring, that sort of thing. And the last part, the spiritual dimension. Here, BPSS treats spirituality as one of the integrated domain, meaning purpose, mindfulness, connection, but it's tailored to individual beliefs without requiring specific practices. 12-step centers on spiritual awakening, surrender to a higher power, prayer, meditation, that's step 11, and principles like humility, forgiveness, service. So 12-step offers a clear spiritual pathway that's helped millions. BPSS provides flexible, inclusive, spiritual integration suitable for secular or diverse clients. Here's what I want you to take away from this. 12-step is great. Celebrate Recovery is great. All right, they're great programs, but they don't address these other dimensions. If a person is in addiction, you need those other dimensions to be addressed somehow. They're probably not going to get what they need in a 12-step program. In fact, it may be more difficult for them. Questions or comments? No. Okay, so let's take a break. We'll come back. I'm going to take you through PowerPoint 11 and then cut you loose for the summer. All right. Okay, see you in what time? Let's come back at 2:20, please. All right. Yeah. So I walk out during the break here. We have these hooks for our curtains. I think I've spoken about it before, that they stick to the wall. And so for the months that it's high enough up, only I could reach it. I'm not allowed to reach up for a few weeks to do that, right? Got everything set, sanded, cleaned, all this sort of thing. Night before last, got them up there, let them sit for 24 hours. Hooked, good. Things are up. Everything's fine this morning when I get up. It's like, okay, all right, we're good. Well, one of them fell. And he must have been laying near the runner in the hallway because it was bunched up. So I was like, okay, never a dull moment around here. And I know you'll miss my dog stories over the summer. Okay, so let's talk about some current issues. This is going to be a shorter part of it, but it's still going to be part of your final exam. Current issues in addiction counseling, professional development, future directions, that sort of thing. Current issues in addiction counseling include persistent workforce shortages, with projections indicating significant deficits in counselors and psychiatrists. In other words, there aren't going to be enough of us, you, me, to go around. A typical addiction counselor will have 30 to 50 clients that he or she works with, 30 to 50. That workload is unsustainable. Okay, it's just unsustainable. So they try to keep them lower, 10, 12, that sort of thing, but there's not enough. Now, what does that do for us as pastoral counselors? Well, for you, me, and all the others, that means that we probably need to be a little more aware of that and help where we can and where we are qualified, all right? There is a significant deficit now, and it's getting worse. Counselors, psychiatrists, that sort of thing. So understand the need is great, but the servants are few. All right. So some other issues that we want to take into account here is polysubstance abuse. Polysubstance abuse. Fentanyl and other drugs. All of this complicates treatments requiring integrated care for complex cases. Back in my day, back in the old days, it was like one drug at a time. You know, it's pot, cocaine, LSD, one at a time. But with these new sets of drugs that are coming out, well, people are using different things at different times due to availability and cost. So we have to be aware of this as well. Of course, stigma, that continues to hinder access to services despite declining overdose deaths. So there is still the stigma, and counselors face high burnout rates amid increasing caseloads and limited resources. Talking to a friend the other day, pastoral counselor, he's pastor and he's pastoral counselor. Very good at what he does. And he has reached a point of not burnout, but compassion fatigue. And the compassion fatigue comes from the fact of the counseling, which is difficult enough because he does have a tendency to personalize these things and bring them inside, empathize too much, but also the pastoral duties that go with just being a pastor. Marrying, burying, preparing for the sermons, budgets, all of that, burnout. And so I want to advise you guys to kind of keep a close eye on yourself, all right? Keep a close eye. Chaplain, you get to go home. You can walk away from the jail. And if you get a phone call, it's going to be from somebody at the jail. It's not going to be from a prisoner. It's going to be from somebody at the jail. Pastors do not have that capability of doing that. One pastor the other day, I asked him, when's the last time you had your phone turned off? He goes, I never turn my phone off. Something could come up. You see some problems there? You get the call at 2 o'clock in the morning where somebody's just not feeling well, or you got one the other night, ask about a scripture, like 1 o'clock in the morning. Pastors generally aren't respected as much as they probably should be. So question becomes, when's the last time you turned your phone off? Mine goes off about 10 o'clock every night. Turn it off. That's it. course, my wife still has her work phone on. That's going to happen this occasion. But there's no case management emergencies generally at 3 o'clock in the morning. So we have to look at this burnout rate for pastors and pastoral counselors. And I would also ask you to consider the possibility of being able to be an ear, if you're not a pastor, an ear for a pastor or pastors. And if you are a pastor, maybe an ear for somebody else, just to, so they got somebody to talk to. You know, no judgment, just talk. Just let them go. Express frustrations, upsets. Just, I can't stress that enough as being just huge in helping people. So please consider that. And if necessary, also find someone for yourself to do that with. Well, we're going to say telehealth expansion. That remains a key issue with permanent policies supporting remote prescribing and counseling. However, digital divides limit equitable access in rural and underserved areas. Telehealth has become enormous. Hospitals here in Corpus, my wife's over 3 of them. One has a psych facility that has psychiatrists that work there. It's a locked facility type of thing, right? They won't come over to the other hospitals to do evaluations because it's clear across town. And that's an hour of their time, 30 minutes going, 30 minutes coming back. And they got to meet clients. They've got things they've got to do. So they've turned to telehealth. Telepsych is what it's called now. And that seems to be a new practice and a fairly effective one. So there you go. What do you do how to use that for pastoral counseling? Don't hesitate to use something that you find secure, Zoom or whatever forums you like. I serve on a board, Crime and Compassion. They have this Google Meet thing. I never heard of it. But now when the board meets, I got to figure out how Google Meet, Google Chat thing works. I'll get it eventually, but the board's only meeting every 3 months. How am I going to remember that? But is it secure? You want to make sure if you're going to do counseling via Zoom or the others, how secure are they? Zoom is pretty secure. I know that. We do that for the school because they had issues back during COVID, and so they put in new security measures. So kind of give that some thought. Zoom's free if you want to use that. Go ahead, Chaplain.
It mentioned your slide mentioned the ruralness of kind of digital problems. We're seeing that go down and down. We're seeing internet access with every Starlink batch of satellites that goes up, more and more data. Of course, I live in Central Florida. We see a rocket go up once a week, carrying different internet access. So that's becoming more and more accessible as time goes on. Yeah,
and it's affordable. That's the deal too. I looked into Starlink here for if a hurricane comes or something like that. Yeah, it sounds like a good plan because our internet was down during Harvey for a week, something like that. But we had cell service, so you can hook your computers up through your cell phone. We can do that. Hotspots. So go ahead, Audrey.
How much is it a month for Starlink where you guys are?
It was $149 for the setup, and then it was like $89 a month, I think.
I was gonna say 50 for my dad. My dad put it on his RV, so he can go to a campsite and rescan it. It's 50, and that's the minimum package. I would assume Dr. Savage has the unlimited for all the stuff that he does online. Right. But my dad is just limited to 5 gigs or so.
Yeah, it's a big deal.
Yeah, I just know in Southern Indiana, like when we went to 5G, it was a big deal. So I still have calls where I have to call a friend like 3 or 4 times before it'll go through sometimes. And I mean, we're not in the middle of nowhere.
Corpus was the same way. We got 5G like 5 years ago, 6 years ago, and it's made a big difference. But still, here on the island, they'll have like 1 or 2 bars at times. So you kind of worry about that. But yeah, so telehealth, telepsych, those things are huge. We just need to kind of keep in mind, all right, there's going to be some glitches at some point. Ethical challenges, of course, rise around privacy, data security, maintaining therapeutic alliances virtually. So balancing technology with in-person care is essential for effective outcomes there. Now, co-occurring mental health disorders demand integrated dual diagnosis. and dual diagnosis treatment as standard practice. And so many clients present with trauma histories that have fueled addiction cycles. So what happens is we end up needing two people to solve one problem. And again, with the shortage of people, that sort of thing, that can prove to be problematic in getting someone who's going to deal with addiction and the other's going to deal with trauma. Counselors must navigate fragmented systems where mental health and substance use services remain siloed. They're separate unto themselves. Holistic approaches addressing both conditions simultaneously show superior recovery results. Funding uncertainties, potential Medicaid cuts that threatens a program's stability, access to care. Policy shifts emphasize law and order approaches alongside treatment expansion. So we also end up needing to advocate for sustained investment, prevention, recovery supports, getting people to buy into the idea this is something that affects you, but you may not know it. Higher taxes, a variety of things. And so reimbursement challenges, that can be an issue also if you're going to be involved with that. Biggest one, stigma reduction. We need efforts to focus on medications for opioid user disorder and that view addiction as a chronic brain disease. So, public messaging promotes whole person care without judgment. All of this means that we as counselors have a job. We have a job to do as pastoral counselors. And we're going to be fitting in some areas and not fitting in others. As it relates to addiction recovery, we can help a lot in those areas. But in diagnosing addiction and helping the person get through addiction, we're in a support role. We can't do much other than that. But we can help support family members, all of that through it as well. So the lack of numbers, the lack of funding, the lack of programs, those are things that affect addiction and addiction recovery efforts. Lots of churches have Celebrate Recovery, or they may have 12-step programs and those sorts of things. What I'm saying is maybe get involved there a little bit and talk to those folks. Just talk to them. You know, I'm here. If I can help, let me know. That type of thing, right? Not going in there. If you haven't been through addiction, you're not going to be able to, relate to it in that way. But you can relate to God and how to get them to God and help them improve their spiritual condition. Okay, off of that. All right, a few more things actually. Counselors play pivotal roles in community education to normalize treatment seeking. Persistent societal biases still delay early intervention. Pastor here allows me, I think it's twice a year, to do a brief presentation on what I do as a pastoral counselor, what I'm available for, and what I can do. I do it during service, so I try to keep it close to the time frame and all that sort of thing. But I will tell you that being allowed to do that has brought more people to me, both inside and outside the church, because they're now aware of what I do. They know my background. And I say, if you're worried about confidentiality, I did not go to prison for telling. And they'll start laughing at that, but it'll eventually settle in, that he might be trustworthy after all to be able to do these things, all right? So that's something to consider. This is what we do. This is how we offer. And talk to them. Let people know if the pastor will allow you to do that. Burnout, compassion fatigue represent major workforce challenges in addiction counseling. People burn out fast if they have too many clients. High emotional demands, heavy caseloads, and secondary trauma will also contribute to turnover in that area as well. Mindfulness and value-based practices help mitigate these effects. Organizational support through supervision, self-care, critical for sustainability. Kratom. Anybody heard of that? This is an emerging substance. You need to know about this. This is the deal that ends up having a lot of people in the ER depending on what they took and how they took it. And it is an herbal substance that has a stimulant and opioid-like effect. Kratom stimulant effects include alertness, rapid heart rate, increased energy, all of that. But it could go just the other way. Relaxation, confusion, pain relief, similar to opioids and sedative effects. Now, that's the new one. There's others. How kratom affects each person depends on how much is taken, its strength or concentration, how it's taken, capsules, powder, tea, the person's medical conditions, and drug taking history. Polysubstance trends demand flexible, individualized treatment planning. Counselors have to stay informed there. So, before we get to the prevention strategies, kratom is a bad thing right now. If you haven't heard of it yet, you will. If you haven't encountered people that have had it or used it, you will. Just like fentanyl. But they don't just use that. Okay? As a counselor, realize if somebody comes in confessing to have taken a particular substance or is currently taking a particular substance, presume that there's something else with it as well. Just presume. Well, doesn't that make... No, that's assume. Presume. That's what you want to do. It is there. It is likely alcohol or pot. Okay? And you're out of your league, and it's time to pass them off to somebody else. If you have a Celebrate Recovery or a 12-step program in your church, ask the leader of that group, how can I get help for a particular person? You don't give the name, but how can I get help for a particular person? What would be your suggestion? What? You're going to ask? Yes. Celebrate Recovery or 12-step or any other group like that that would be important to consider in concern of your client. Ask them. They'll know. All right? Questions about that? Comments? Final note on that particular point, just getting close. Prevention strategies increasingly target multiple substances simultaneously, just so you're aware. When people are brought into the hospital and they have a drug detox or a drug screen given, you're seeing 2, 3, 4 substances that will show up on those typically now. Typically. Okay, so research is going to focus on long-term recovery outcomes beyond just abstinence metrics, quality of life, functional improvement. They'll guide program evaluation. Neuroscience advances inform brain-based interventions like neuromodulation, where they're stimulating certain parts of the brain in order to decrease the craving. But it's not solving the problem. Translational research bridges lab findings to bring to clinical practice. Basically, what that means is take the research and make it practical somewhere within these lab or these practices. Continuing care models, they're going to emphasize chronic disease management for addiction, peer support, recovery coaching. All of these will be formally put into these systems, and they're beginning to work. As a pastoral counselor, what do you take away from this class? Here's what I want you to take away from. There's people that are addicted that are all around you and probably in your church. I just want you aware of it. I want you to understand what the programs were and how they work. People don't have to go through the DTs anymore when they're detoxifying. I want you to know that you have a job to bring them closer to God, and you can do it. And hopefully in this class, you've learned some of those things to do, or at least have given them a thought that it might be a good idea to know those. All right? Any questions or comments? No. All right, so take your final exam before a week from next Friday. Okay. If you don't, I will come wherever you live and I will hunt you down. All right. I want to turn my grades in. Don't. I'm not coming to Ocala. No. I was born in Ocala. You kidding me? All right. So that's about it for this class. If you need anything over the summer, do not hesitate to reach out to me. You have questions, something comes up, there's a glitch in the system. I'm still working even when you guys are not in class. So I'm still working. I'm not taking the summer off. So let me know. Don't hesitate to reach out. That's what I'm here for. All right. Anything else before we close? All right. I expect to see all of you in class in the fall. And if not, Audrey, I know where Indiana is vaguely, but I will figure it out. All right.
I registered.
Oh, good. All right. Good on you. All right, Pastor Josh.
I
always
didn't
good
see
to
the
see you.
classes I needed, but I did register.
We'll figure it out. All right, Pastor Josh, you take care. Chaplain. All right, Audrey, talk to you soon. Bye-bye.